Hello, everyone, and good afternoon. My name is Carl, and together with me is Maurice. So, for our part, we will be talking about epilepsy. We're going to be talking about its pathophysiology, the factors that may induce or potentiate it, and we will also give an overview of its clinical presentation, including its diagnostic and laboratory tests, the drugs of choice for its treatment, and lastly, we are going to evaluate the therapeutic outcomes. So we start off by defining what an epilepsy is. So an epilepsy is a group of neurological diseases characterized by recurrent seizures or mga seizures nga gabalik-balik. Kung may ganitag ang isa ka seizure kay provoke na siya, it means na kani nga seizure kay nasa a direct na cause such as a head injury or it may be an infection or a low blood sugar. Kung may ganitag ang isa ka seizure kay unprovoked siya, this means that it does not have an immediate cause. So a patient is considered to have an epilepsy if they have at least two unprovoked seizures occurring greater than 24 hours apart, or if they have one unprovoked seizure and a probability of further seizures of at least 60% after two unprovoked seizures occurring over the next 10 years. And lastly, if we have a diagnosis of epilepsy syndrome. So, kaning mga seizures, they result from a sudden surge in the brain's electrical activities. Basically, seizures occur if there is an imbalance of how the brain sends signal to the rest of the body by the use of neurotransmitters. Kaning mga neurotransmitters, as a review, muna sila mga molecules used by the nervous system to transmit messages between our neurons. So depending on which part of the brain is affected, a seizure may have different manifestations. And apil na rin ng loss of awareness, unusual behaviors or sensations, uncontrollable movements, or loss of consciousness. So yes, later we will know that there are different types of seizures characterized by different durations. And we will also know na ibang seizures can occur with or without loss of consciousness. So as stated by the book, seizure initiation is likely caused by an imbalance between the neurotransmitters which excite or activate the nervous system and those that inhibit or stop the nervous system from sending signals. So later, we will talk more about this, the excitatory and inhibitory processes in the brain. Speaking of the brain, this slide presents the brain's different lobes. Later, we will see the different classifications of seizures and the parts of the brain nga ilang ginapektuhan. So zooming in on the brain, we will see that it is comprised of complex network of billions of neurons. So kaning neurons, they communicate with each other through their dendrites and axon, and they communicate using neurotransmitters. The synaptic cleft, also known as synaptic gap, muna siya ang space between the axon of one neuron and the dendrites of another. This is where the communication between neurons occur. We have to remember nga ang neuron nga ga-transmit og signal mo ni siya ang ginatawag nga presynaptic neuron, while the neuron receiving the signal is called the postsynaptic neuron. Generally, incoming signals are received at dendrites, while outgoing signal travels along the axon to the nerve terminal. In order to achieve rapid communication over its long action, the neuron sends electrical signals from the cell's body to the nerve terminal along the axon. These are known as nerve impulses, or what we call action potentials. An action potential is essentially a brief reversal of electric polarity across the cell membrane. In other words, ang action potential kay wave siya of depolarization and repolarization. It is not literally an electric current, it's just a series of voltage-gated ion channels opening and closing. So important yung kining action potentials because every time we do something like kuha na tatong cellphone or magluto tag pinakpit, our brain transmits electrical signals to the rest of our body, and these action potentials allow our muscles to coordinate and move with precision. So we can say that it is just a series of voltage-gated ion channels because if we look at a neuron under a microscope, we will see that each electrical signal that passes through it is just ions flowing in and out through protein channels. The way this ion flow is controlled is through neurotransmitters, which signals molecules and receptors. So kaning mga neurotransmitters, gabind din sila sa mga receptors and basically ilang ginaingnan ng cell to either open up the ion channels and relay the electrical message called excitatory neurotransmitters or Sirad-an ba ang ion channels and stop the electrical message called the inhibitory neurotransmitters, which we will talk about more in detail very shortly. So in a neuron, which is in a resting state, we have to remember that the cell is more negative on the inside. At this resting state, there are concentration gradients of sodium and potassium across the cell membrane. There's more sodium outside the cell and more potassium inside the cell. Kani mga gradients kay gina-maintain ni siya sa atong sodium-potassium pumps, which constantly brings potassium in and pumps sodium out of the cell. So here we have an image of a resting neuron or a neuron in a state of relaxation. So if we were to take an instrument and find the millivolts of the inside of the cell, it would show us a value of negative 70. Negative ang iyang value due to more potassium ions inside the cell. This voltage is called the resting membrane potential. It is caused by the differences in the concentrations of ions inside and outside of the cell. Kay kung ang membrane nato equally permeable siya sa tanan ions, each type of ion would flow across the membrane and the system would reach equilibrium. In other words, ang negative nga charge sa sulod sa cell kay na-create siya by the cell membrane, being more permeable to potassium ion movement than sodium ion movement. The cell processes sodium and potassium leakage channels that allow the two cations to diffuse down their concentration gradient. However, the neurons have more potassium leakage channels than sodium leakage channels. Therefore, ang potassium kay mas ga diffuse siya out of the cell at a faster rate than the sodium leaking in. Because more cations are leaving the cell than are entering, this causes the interior of the cell to be, again, negatively charged. Now let's talk more about excitatory and inhibitory neurotransmitters, which are the main factors that increase or decrease the likelihood of the neuron to fire an action. So let's first talk about excitatory neurotransmitters. So from the name itself, excitatory, they excite the neuron, basically making them more positive. Yan ang ginabuhat by allowing the influx of ions like calcium and sodium into the cell. And this causes it to fire off the message, meaning the message continues to be passed along to the next cell from neuron to neuron. Furthermore, ang main excitatory neurotransmitter nato sa brain kay glutamate, and NMDA ang primary receptor nga ga-respond sa glutamate by opening ion channels that let calcium in, a positive ion that tells the cell to send signals. So some patients with epilepsy seem to have fast or long-lasting activation of these receptors. So here is an image about the effect of an excitatory neurotransmitter on the cell. Basically, iyang ginahimog mas positive ang inside sa cell, and we can see here sa reading from negative 70 nahimo siya 0. There is an excitatory effect, meaning kaninga neuron mas likely ni siya to fire an action. And as a result, this glutamate or our excitatory neurotransmitter is going to be pulsating throughout the central nervous system. Inhibitory neurotransmitters, on the other hand, block or prevent the chemical message from being passed along any further. Kaning gamma aminobutyric acid, glycine, and serotonin, mga examples ni sila of our inhibitory neurotransmitters. Pero ang main good nga inhibitory neurotransmitter of the brain is GABA, which bind to GABA receptors that tell the cell to inhibit the signals by opening channels that let chloride ions, which are mga negative nga ions that tell the cell to inhibit signals. Studies have shown that patients with epilepsy seem to have genetic mutations in which their GABA receptors are dysfunctional, so dili nila ma-stop ang signals very well. In addition to potentially having a primary genetic cause, these receptors and ion channels might be affected by all sorts of things like brain tumors, brain injury, or infection. So inhibitory neurotransmitters have ligand-gated chlorine channels. The main receptors for these channels are GABA and glycine. Once neurotransmitters bind to these receptors, as shown here, it allows an influx of negative na mga chlorine ions to enter the cell. And once these chlorine ions enter the cell, they cause the plasma membrane to be hyperpolarized. due to their negativity. This causes the postsynaptic cell and firing of the action potential to be inhibited altogether. So the excitatory and inhibitory process of the brain might still be confusing for some of us. So on the next slide, I have attached a short video about it.
Now, simplistically, seizures can be viewed as the result of an imbalance between inhibitory and excitatory processes in the brain that produces either too little inhibition or too much excitation. In order to gain better understanding of how this happens, we need to take a closer look at how neurons pass signals to one another. So as you probably already know, the main form of communication among neurons occurs through the traveling wave of electrical excitation, known as an action potential. An action potential is orchestrated by the synchronized opening and closing of ion channels. Now, if we look at the simple excitatory neuron, when addressed, the inside is slightly more negative than the outside. An action potential starts when voltage-gated sodium channels open, allowing positively charged sodium ions to rush into the cell, thus reversing depolarization of the membrane. Consequently, membrane depolarization leads to opening of high-voltage activated calcium channels, which then allow positively charged calcium ions enter the neuron, thereby triggering release of glutamate from the vesicles into the synaptic cleft. Next, glutamate binds to two types of receptors on the postsynaptic neuron. First, the AMPA receptors, that upon binding of glutamate open and permit entry of sodium ions, and the second, NMDA receptors, that open and permit entry of calcium ions. In addition to that, calcium may enter through low voltage activated calcium channels, also known as T-type calcium channels, which open in response to small depolarizations at or below resting membrane potential. So all this influx of positive ions again leads to depolarization and propagation of action potential. Now, as you can imagine, if there's too much glutamate around, neurons can become hyperexcitable and a seizure may result. But this normally doesn't happen, because we also have inhibitory neurons around that put brakes on excitatory impulses. These inhibitory neurons release neurotransmitter GABA, which binds to GABA A receptors on the excitatory neuron, causes them to open and allow negatively charged chloride ions to enter in. This causes the membrane potential to be more negative on the inside relative to the outside, thus limiting the neuron's ability to respond to further stimulation. Finally, once GABA dissociates from the GABA A receptor, it becomes removed from the synaptic cleft by reuptake through the GABA transporter 1, GAT1 for short, and then degraded by an enzyme gamma-aminobutyric acid aminotransferase, GABA-AT for short. So again, as you can see, just like with excess of glutamate, too little GABA can also allow neurons to become hyperexcitable, which may lead to seizures.
Thank you guys for listening to the video. So in summary, excitatory neurons stimulate others to fire action potentials and transmit electrical messages, while inhibitory neurons suppress this process, preventing excessive firing. A balance between excitation and inhibition is essential for normal brain functions. In epilepsy, there is an upregulation of excitation and or downregulation of inhibition, causing lots of neurons to fire synchronously at the same time, causing a seizure. Now let's talk more about the classifications of seizures. We can start grouping the seizures by the region of the brain that is affected. When the affected area is limited sa isa lang ka-hemisphere or one-half lang sa brain, or sometimes even a smaller area like isa lang ka-lobe, we call it a partial or focal seizure. These seizures can be subcategorized by whether someone remains conscious during a seizure, which is called simple partial seizure, or whether someone has impaired consciousness during the seizure, which is called a complex partial seizure. According sa mga people nga naay simple partial seizures, they claim to have strange sensations like hearing or tasting something, but can also involve jerky movements in specific muscle groups if neurons controlling those muscles are affected. So if the jerking activity starts in a specific muscle group and spreads to surrounding muscle groups as more neurons are affected, it is referred to as a Jacksonian march. Typically, the person is conscious, meaning na they are awake and alert, and they will usually know that something's happening and will remember the seizure afterwards. Complex partial seizures, on the other hand, involves total loss of consciousness gyud. So completely or having impaired awareness and responsiveness. So dili yun nila ma-remember. Daw kay chance na dili nila ma-remember what happened during a seizure. So here, not the illustration of what was talked about. So in partial seizures, we have simple and complex. Simple partial when the patient is conscious. Complex when the patient is unconscious during a seizure. Dapat din yung Jacksonian march if the jerking activity starts in a specific muscle group and starts to spread to surrounding muscle groups as more neurons are affected. Next, we have generalized seizures, which typically occur sa mga bata. Muna sila ang mga seizures nga dili lang ga-affect sa isa ka area sa brain but to all the areas of the brain. And there are 6 types of generalized seizures. First is absence seizures. Ginatawag sila nga absence seizures kay they are characterized by staring into space with or without subtle body movements such as eye blinking. And they only last between 5 to 10 seconds. And kani nga mga seizures pwede silang mahitabo in clusters as often as 100 times per day and cause a brief loss of awareness. Next, we have tonic seizures. They cause muscle stiffening and may affect consciousness. Kani nga mga seizures usually affect the muscles in the back, arms, and legs and may cause someone to fall to the ground. Next, we have atonic seizures. Kaniyang mga atonic seizures kay ginatawag po sila drop seizures. Ginatawag sila drop seizures kay ang muscles nga ilahang ginaapektuhan mostly kay ang muscles atong legs. Next, we have clonic seizures. Clonic seizures are associated with repeated or rhythmic jerking muscle movements. These seizures usually affect the neck, face, and arms. Next, we have myoclonic seizures. Myoclonic seizures usually appear as sudden brief jerks or twitches and usually affect the upper body and arms. Tonic-clonic seizures, previously known as grand mal seizures, are the most dramatic nga type sa atong epileptic seizure kay they cause an abrupt loss of consciousness and body stiffening, twitching, and shaking also. They sometimes cause loss of bladder control or biting of the tongue. So here's another illustration summarizing generalized seizures and its 6 subcategories. Basta ang seizures gani kay galast sila for longer periods like over 5 minutes of ongoing seizures or having multiple seizures without returning to normal in between. This is called status epilepticus, and these are usually a tonic-clonic subtype of seizures, but it can also be caused by other subtypes that do not involve convulsions. So kani nga situation kay gina-consider gini siya as a medical emergency and it can be life-threatening if not treated immediately. Due to the severity of these seizures, patients are often treated acutely with benzodiazepines, which help the enhancement of the effect of the inhibitory neurotransmitter GABA to stop the overexcitation sa atong nervous system. So GCSE being the most common and severe form of status epilepticus, it occurs when the time of ongoing seizure activity extends past 30 minutes, after which there is a risk of long-term consequences. So there are actually 4 stages of GCSE or generalized convulsive status epilepticus. These are number 1, stabilization, number 2, initial therapy, number 3, secondary therapy, and number 4 is third therapy. During the first therapy phase of GCSE, taga-seizure kay ga-produce og unmarked increase in plasma epinephrine, norepinephrine, and steroid concentrations that may cause hypertension, tachycardia, and cardiac arrhythmias. Muscle contractions and hypoxia can cause acidosis, hypotension, shock, rhabdomyolysis or the breakdown of muscle tissue, and secondary hyperkalemia. And acute tubercular necrosis may ensue, which is the condition that causes the lack of oxygen and blood flow to the kidneys. In secondary therapy phase, beginning 30 minutes into the seizure, the patient begins to decompensate, or there is an inability of the heart to maintain adequate circulation. And this may become hypotensive with compromised cerebral blood flow. Serum glucose may be normal or decreased, and hyperthermia, respiratory deterioration, hypoxia, and ventilatory failure may develop. On the third therapy phase, it consists of refractory and super-refractory GCSE. Basta kanimo yung taog refractory status epilepticus, this can be defined as status epilepticus that continues despite treatment with benzodiazepines and one antiepileptic drug. Status epilepticus that continues for more than or equal to 24 hours despite anesthetic treatment are referred to as muna na siya imuang suprarefractory GCSE. So, during the third therapy phase, motor activity may cease, but electrical seizures may persist. Now let's talk about the factors that may induce or potentiate epilepsy. Epilepsy kay wala gyud siya identifiable nga cause in about half the people with the condition. But in the other half, the condition may be traced to various factors. Isa na diri ang genetic influence. Some types of epilepsy, which are categorized by a type of seizure you experience or the part of the brain that is affected, run in families. In these cases, it's likely an genetic influence. Researchers have linked some types of epilepsy to specific genes, but for most people, genes are only part of the cause of epilepsy. Head trauma or head trauma as a result of a car accident or other traumatic injury can also cause epilepsy because it can damage specific parts of our brain. Brain abnormalities. Abnormalities in the brain including mga tumors or vascular malformations can cause epilepsy. In fact, stroke is a leading cause of epilepsy in adults older than 35. Infections like meningitis, HIV, or some other parasitic infections can cause epilepsy. And also prenatal injury. You have to remember na before childbirth, babies are very sensitive, especially sa ilang brain. So they're very sensitive to brain damage that could be caused by several factors such as infection of the mother, poor nutrition, or oxygen deficiencies. This brain damage can result in epilepsy or cerebral palsy. And lastly, we have developmental disorders. Epilepsy can sometimes be associated with developmental disorders such as autism. And now let's talk about the diagnostic and laboratory test for epilepsy. Specifically, EEG is very useful in the diagnosis of various seizure disorders, successfully diagnosing about 50% of patients with epilepsy. Brain scans are used to find out kung nabay any anatomical abnormalities like brain tumors or abnormal blood vessels that could be causing the seizures, of which could be treated surgically. In some cases, serum prolactin levels may be transiently elevated, particularly after generalized tonic-clonic seizures. A serum prolactin level obtained 10 to 20 minutes of GTC can help differentiate kung ang seizure ba kay pseudo lang siyang seizure or done on purpose. However, it cannot tell whether the seizure caused temporary loss of consciousness. Furthermore, laboratory tests may rule out the treatable causes of seizures that are not epilepsy.
So for the drugs of choice for the treatment of the disease or disorder. For the absence seizure, petit mal, the drug of choice is ethoxoximide, Zarantin. Zarantin is a prescription medicine used to treat the symptoms of absence seizures, and its generic name is ethoxoximide. Zarantin may be used alone or with other medications, and it is indicated for the control of absence epilepsy. Zarantin is an anticonvulsant succinimide. Ethoxoximide should not be used in patients with a history of hypersensitivity to succinimides. For the alternative drugs for absence seizure, clonazepam is a prescription drug that is used as a treatment to prevent and control seizures. This medication is known as an anticonvulsant or anti-epileptic drug, which is used in the treatment of epileptic seizures. This drug is also used as a treatment for panic attacks, insomnia, and symptoms related to the chronic anxiety and anxiety disorders. Clonazepam works by calming your brain and nerves. For the valproic acid, it is used to treat certain types of seizures. This medicine is an anticonvulsant that works in the brain tissue to stop seizures. Valproic acid is used to treat bipolar disorder. It's occasionally used to prevent migraine and can also be used to treat epilepsy. This medicine is only available on prescription. For the atonic seizure, the drug of choice is clonazepam. Clonazepam belongs to a group of medicines called benzodiazepines and is available on prescription only. It is used to control seizures or fits due to epilepsy, involuntary muscle spasms, panic disorder, and sometimes restless leg syndrome. Clonazepam works by increasing levels of a calming chemical in your brain. This can relieve anxiety, stop seizures, and fits or relax tense muscles. Clonazepam is a drug of choice for atonic seizure since atonic seizure causes a loss of muscle control and these drugs can relax tense muscle. For the status epilepticus that lasts 20 to 30 minutes, the drug of choice is lorazepam, and its former drug of choice is diazepam. Lorazepam has emerged as the preferred benzodiazepine for acute management of status epilepticus. Lorazepam and diazepam act quickly in the brain to stop seizures. Lorazepam differs from diazepam in two important respects. It is less lipid soluble than diazepam with a distribution half-life of 2 to 3 hours versus 15 minutes for diazepam. The anticonvulsant effects of lorazepam last 6 to 12 hours, and the typical dose ranges from 4 to 8 milligrams. This agent also has a broad spectrum of efficacy, terminating seizures in 75 to 80% of cases. Lorazepam has a much longer duration of anticonvulsant action than diazepam and has an equivalent onset of action. For the pediatrics, drug of choice in status epilepticus is phenobarbital luminal. Phenobarbital is widely used in the treatment of children with febrile seizures, although there is concern about possible behavioral and cognitive side effects. Phenobarbital is useful in treating many kinds of seizures in children. It is often considered the first choice to treat certain seizures in newborn infants. Phenobarbital also has been widely used to prevent seizures that sometimes accompany a high fever in infants or young children. For generalized seizure, the drug of choice is valproic acid tepakin. For generalized seizures, valproic acid is recommended as first-line therapy. Valproic acid is a broad-spectrum antiepileptic drug and it is used to treat certain types of seizures. This medicine controls seizures by raising levels of certain chemicals in the brain that are helpful for calming nerves. Valproic acid is sometimes used together with other seizure medications. For the next slide, it shows the anti-seizure drug dosing and target serum concentration ranges. The antiepileptic drugs in the table categorize in three generations. For the evaluation of therapeutic outcomes, the goal therapeutic outcome for all ASD is seizure freedom or reduction in seizure frequency while minimizing adverse effects. Monitor long-term for seizure control, side effects, social adjustment including quality of life, drug interactions, compliance, and side effects. Clinical response is more important than serum drug concentrations. Next is ask patients and caregivers to record severity and frequency of seizures. Recording the seizure may help the doctor determine what kind of seizures you are having or rule out other conditions. A record will also provide information regarding the frequency and duration of the seizures. Medication adherence should be assessed continually. Assessment of the medication adherence in these patients should ascertain their ability to identify the drugs for their disease condition correctly, the correct frequency of administration, and the adherence to the prescribed dosage. The morbidity and mortality associated with GCSE can be minimized by the rapid implementation of a rational therapeutic plan. Next is an EEG or electroencephalogram is an extremely important tool used to determine what abnormal electrical activity has been aborted, but also can assist in determining what anticonvulsant was effective. Electroencephalography is often helpful in evaluation of patients presenting with a seizure. In this test, electrodes are attached to your scalp with a paste-like substance or cup. The electrodes record the electrical activity of your brain. The goals of treatment of epilepsy: control or reduce the frequency and severity of seizures, minimize side effects, and ensure compliance, allowing the patient to live as normal a life as possible. Complete suppression of seizures must be balanced against tolerability of side effects, and the patient should be involved in defining the balance. Side effects and comorbidities such as anxiety and depression, as well as social issues such as driving, job security, relationships, and social stigma, have significant impact on quality of life. The goals of treatment of status epilepticus are: identify GCSE subtype and precipitating factors, terminate clinical and electrical seizure activity as soon as possible, and preserve cardiorespiratory function, minimize side effects, prevent recurrent seizures, and lastly, avoid pharmacoresistant epilepsy and or neurologic sequelae. The overall goal of treatment is to ensure the best possible quality of life according to the patient's individual circumstances. The goal of therapy is to completely control seizures without producing unacceptable medication side effects. Patients who do not achieve complete seizure control should be referred to an epilepsy specialist, since new medications and surgical treatments offer patients unprecedented options in seizure control. In this diagram, it shows the suggested algorithm for treatment of epilepsy.